we might make a start. So it's my pleasure to welcome you this evening. We're so glad to have amongst us in the audience tonight donors, supporters and research collaborators of the Florey for this special event for National Stroke Week, and we thank you all for joining us. So my name is Peter Van Weingarten. I'm the newly appointed Executive Director and CEO of the Florey. In fact, this is day number 5, so you'll have to excuse me if I'm a little bit. Thank you. So this evening's event's obviously particularly exciting for me as I'm so new in the role. Many of you will have met my predecessor, Professor Trevor Kilpatrick, who handed over the baton after 2.5 years of exceptional leadership. So it's big shoes that I have to fill, and I'll be doing my best. So I'm really delighted to be emceeing tonight's proceedings and to have the opportunity to meet many of you in person. So before we begin, I'd like to acknowledge the traditional owners of the lands on which we're meeting today, the Wurundjeri people of the Kulin Nation, and I pay my respects to their elders past, present and emerging. And I'd like to extend that respect to any Aboriginal and Torres Strait Islander peoples we have amongst us in the audience tonight. So National Stroke Week marks the flagship health promotion campaign of the Stroke Foundation, and we at the Florey are proud to be active supporters of this important initiative. I'd like to extend a special welcome to members of the Stroke Foundation team. We're so pleased that you could join us here tonight. And now, Stroke Week's a really important opportunity to learn and act on the signs of stroke enshrined in the F.A.S.T acronym. Should be shown on the screen there. So F for face weakness, can the person smile? A for arm weakness, can they raise both arms? S for speech, can they speak clearly and understand what you say? And finally, T for time, because we know that there is an urgent need to act and seek medical attention if you see any of these signs. So if you're able to join us outside after the event, please speak to members of the Stroke Foundation who are here tonight and have a chat about the F.A.S.T acronym. The astute members of the audience will note that one of our speakers has the acronym enshrined on his socks, which I think is really taking the commitment to the next level. So we're now in for a real treat this evening, thanks to a lineup of fabulous speakers that we've assembled. We're going to hear aspects of a broad spectrum of research that we have underway at the Florey, spanning from treatments for acute stages of stroke through to stroke rehabilitation. We're going to hear shortly from a leading stroke researcher, and we'll then be treated to an interactive panel of experts on the topic. So as we go along, I'd like to ask you to think of questions, store them up, and then save them for our panel, because you'll get the chance to ask questions. So without further ado, I'd like to introduce my colleague, Professor Vincent Teese. Professor Teese is head of our translational research and neuroimaging stroke group at the Florey. He's a neurologist at Austin Health and a researcher who specialises in acute stroke treatment, stroke prevention, stroke in young people, and the role played by genetics in stroke. So please put your hands together to welcome Professor Teese.
Good evening, and thank you for your kind introduction, and thank you for attending. So, this is not Harry Potter, this is me. 30 years ago, I was a young junior doctor, and when you would enter a hospital, my first stroke patient I remember vividly was an elderly gentleman, and he had all the signs of stroke. He wasn't able to talk anymore, had a right arm weakness, as shown in the F.A.S.T acronym. And I was with a senior heart specialist. There was no neurologist in that hospital, and he would open the curtain, glance at the patient, and then take the partner apart and say, "We can't do anything. There's no treatment available for your partner." And that sort of inspired me. What can we do about this condition? And A few months later, I was an advanced trainee in neurology, and there was this paper that came out in 1995, the 1st of December, and that showed that you could actually treat stroke patients with a clot-busting agent. And we were very enthusiastic about this paper, and my mentor, he said, "Vincent, you're starting in neurology, why don't you take this on and create a protocol for our hospital to start administering this treatment?" And a few months later we actually did, and maybe it was luck, it really helped that person. And that shows you how a clinical trial that tests a drug can actually change lives for decades onwards, because we're still using the same drug at the moment. And that spurred a revolution in how we treat acute stroke at the moment. And that's why I think the power of science and research to really move things along, and how we can use biology, understanding how clots work, then translating that into testing it in the clinic, and then trying to implement it across the world. Because it took so many years, and you'll see some figures later on, that we're still not there where we want to be, even though that treatment has been invented 30 years ago. And I think the Florey sort of helps pushing all these boundaries, and that's why we're here tonight to discuss these possibilities that can emanate from research. Okay, so just to come back a little bit to what is a stroke. Stroke is a disease of the brain where the blood vessels are affected, and either you can get a blockage of the blood vessel that supplies blood to the brain, and then part of the brain is damaged because it doesn't receive enough nutrients. That's called an ischemic stroke. And then we also have a brain bleed or brain hemorrhage. That's when a blood vessel bursts inside the brain, and with high pressure it damages the brain tissue around it. So problems with the blood vessels supplying blood to the brain is stroke. And it's unfortunately quite common. In Australia, about 40,000 people a year will have a stroke. And it has a high mortality. About 5% of all deaths in Australia are due to a stroke. So it's extremely costly. Acute care, but also follow-up care, and often that is not only borne by society and healthcare system, but also by carers and relatives. It's an important economic burden. Many people survive a stroke and live years long with the consequences of a stroke. And that's about 500,000 Australians are living with the consequences of a stroke. What is the risk of having a stroke in your lifetime? Well, 1 out of 4 people will have a stroke. My dad had a stroke, and you probably know all in your families, relatives who've had a stroke. So it's a very common condition. But what can we do about stroke? What are the treatments that we currently have available? A treatment that probably is underappreciated is we need stroke units. Specialized areas within the hospital where a whole team, doctors, but more importantly, I think, nurses, allied health people work together to provide the care that a stroke patient deserves in terms of diagnosis, but also getting back on their feet, nursing care, managing blood pressure, sugars, feeding, all these things that can be lost due to a stroke, and managing them early on by a dedicated team. And that has been proven to improve outcomes and reduce mortality with stroke. And it doesn't matter if you're young or old, or if you're severely affected by a stroke or have a relatively minor stroke, it has been proven to be beneficial. And it requires a lot of investment, but the payback is tremendous. So it's really important that we focus on creating more stroke units, also in Australia, even though this has been proven now for at least 50 years. Thrombolysis is the clot-busting drug. So for the majority of strokes are ischemic stroke, where a blood vessel is blocked. We can have 2 ways to unblock the blood vessel. One is by giving a chemical, an agent, a medicine called clot-busting or thrombolytic agent. And they are quite effective, but they're not perfect. They have limitations. They cannot be given to everyone, and the important thing is they have to be given very early on. That's why we emphasize the T in the F.A.S.T algorithm. We have to administer it within the first hour. So it requires a very dedicated system to administer it quickly. The fastest way is actually to do it at the home of the person who is suffering from a stroke. And, a few years ago, the mobile stroke unit that we may have seen around here in Melbourne was also, all the ideas for that came from out of Florey trials and grants, so it's really important that we, again, the link with research, highlight the link with research. So what they can do in that ambulance, it's actually a mini hospital where we can look at bloods, but we can most importantly look at a scan. There's a neurologist, and they can decide how we can administer this treatment now, instead of going through a hospital, then being processed in a hospital, getting the scans there. It takes so much time because hospitals have so many priorities. There's a trauma going on, there's a very sick patient here, there's a fall. Having that dedicated team, just like a stroke unit, but out near the home where the accident, where the stroke happens, is important. The other more specialized treatment that we have is not taking the clot out by a chemical, is by using a little device that a very specialized team can take out of the blood vessel. It requires a special set of skills. There's only 15 or so people in Victoria that do this procedure, but that also has been proven over 10 years already to be a game changer in acute stroke management. So really we can do a lot, but there are still gaps. Unfortunately, we're not there yet. Stroke is still not cured. What are the gaps? Well, first of all, your question tonight will be, how can I prevent a stroke? Well, actually, we know quite well what to do to prevent stroke, but how can we create the systems that it becomes more efficient? There's so many gaps. We have the knowledge, science have established, we need to treat risk factors, etc. But when we see how actually it's adopted in clinical practice, in the community, it's relatively poor. So we can do better there. Acute treatment, I told you about timely access. Time is brain. The F.A.S.T algorithm has a T in it. But what if you live remotely? How can we help? What about implementing thrombolysis and thrombectomy? If there's only 15 people around and there's so many strokes happening in Victoria, people miss out. So how can we translate that evidence again into clinical practice? And even though we provide the best care, and you're a candidate for a thrombectomy or a clot retrieval procedure, about half of the people still will require help after that. So developing new drugs, new agents, new strategies to help people who have a stroke is really important. What about the phase after stroke? Many people with stroke will have impairments in mobility, in thinking, in speaking. How can we harness the brain's repair mechanisms to really improve these functions that we all require on a daily basis and sometimes define our essence? So unfortunately we have quite good tools on rehabilitation, but again it's not equally distributed around Australia, and it depends a little bit on the postcode where you live or the community where you live, whether you will have access to excellent care or not. And we are also at the Florey trying to improve access, and we'll give you some specific examples later on. Next, we don't have yet a medication that really targets these brain mechanisms that improve neural function and repair the brain. Ideally, we have a chemical, a medicine combined with a therapy provided by a physio or an occupational therapist, and really strengthen the mechanism that we have in our brain to recover, because some people recover really well after their stroke, and an identical person may have a very limited recovery. We don't really understand why that happens, and that's a really important target, I think, for the future, because we may improve on the acute side, we also need improvements on the chronic or more subacute side after stroke. So what are we doing at Florey? I have a particular interest in young people that have had a stroke. Unfortunately, about 15% of the people will have a stroke when they're younger. We are targeting the youngest of the young. Everyone here is young, but we're looking at the 18 to 45 population of stroke, and they have really special needs, and we'll talk about a little bit about hidden disabilities. They may recover quite well outward looking, they can speak, they can walk around, and their mobility may be well, but they often have also invisible disabilities, problems with thinking, problems with returning to work, problems with fatigue that is really pervasive and actually affects quality of life in a very important way. So we are blessed by having created this big team across 2 states, in Victoria and South Australia, where we provide dedicated services, and we're researching this, whether it's really actually viable to continue this and to make it sustainable and embedded in the healthcare system. Yeah. Okay, I'll skip a few slides. Another program that we're working on is how to measure monitor stroke care across Australia. What are the numbers? We need to know, are we improving our care? Are we doing bad with our care? Are strokes increasing? Are there fewer strokes? And can we also help the hospitals in providing better care? Professor Cadilhac's team is actually leading the whole Australian Stroke Clinical Registry, where we have 65 hospitals that provide data, and that tells us how many strokes are coming in and what is the quality of care that's provided, how many people receive these procedures. And that's really important to know from a national basis, but also for the individual doctor to know what they need to do in their individual circumstances. We, for instance, know that only 75% of people are treated in the stroke unit, and only 1 out of 3 people receive thrombolysis within the target time. And then people are discharged, they require medication to control their blood pressure, one of the most important factors in getting a stroke, but after stroke even important to prevent the second one. But we're not doing really well. So we know this so that we can create targets and campaigns to improve these factors and improve the hospitals and feedback to the clinicians. So really important work that is happening to provide individualized care. And we receive these letters, and then we look at them in our team in the hospital, and we say, oh, we really need to work on this project. We really need to work on that aspect of our hospital's care, because we're lagging behind, and we're very competitive in medicine. We look at other hospitals, they're doing better. Cannot be that hospital. And unfortunately, we can only guess at the moment which hospital it is, but soon that will change. We'll have open data for everyone, so we know, okay, this hospital is really... And that's also important to the public, because we have a real responsibility to the public to provide optimal care wherever you live, wherever you are in Australia. And this is also linked to many other aspects, so that we are highly embedded within the whole system in Australia, because stroke is linked to diabetes, stroke is linked to readmissions for other conditions. How do we know that our health system is working well? Well, we need these registries. I think the Florey supports these registries in neuroscience, especially in stroke. I think maybe others must be coming in the future to really target, and we can make them talk to each other, so that we have a good vision of how our healthcare in general is functioning. And also we use a lot of technology now. All hospitals are becoming more and more digital, and we need to make sure that they interoperate and that we get all these data together. So really the era of big data and stroke, and we're very fortunate that Dom has such grant writing skills that you get all this money to do that, to get fancy computer scientists to work together with clinicians to create these monitoring systems. And then we're also very fortunate to have Professor Leanne Carey with us, who is a neuroscientist, an occupational therapist by background, and she focuses on translating evidence into practice about particular aspects of rehabilitation and recovery. For instance, we have spoken about hidden disabilities. Well, this person in the picture, she is called Karen, and she had a stroke, and outwardly you wouldn't see much, but she cannot use her arm because it doesn't sense anything, it doesn't feel anything. Sensation is gone, it cannot use that creates quite a lot of problems. And Leanne is one of the first in the world who has created a program to really target and treat people with sensory disturbances after stroke, using a background in neuroscience, translating that into a program that was tested in a randomized trial, and then now trying to spread it out all across Australia and worldwide. That's a fantastic story from neuroscience into clinical practice. And the next program is to use digital apps, digital tools to improve the therapeutic relationship with a therapist by using a mobile phone that provides exercise for the person who had a stroke to recover, and then also use data like exoskeleton that provides real-time information back to the clinician to see how they're doing. So very innovative programs that we are creating. And I think now it's time for the Q&A. I think it's more interesting than the things I've spoken about.
Two quick observations after your talk, Vincent. Number one, it's very clear how passionate you are and how gifted you are at communicating a complex topic in such an approachable manner, so thank you very much. The second thing that really stands out to me is how tangible the outcomes of your research actually are. Often when we talk about research, we're talking about esoteric things that are hard to relate to, but this is a program of research that we can really see tangible benefits for, and I think that's a credit to your whole team, so thank you. So I'd like to start with you, Brooke, if I may, because I think it's really important that we get a lived experience perspective before we delve into the rest of the panel. So I wonder if you could share with us parts of your story.
Absolutely. So when I was 13, I was just like any other teenager. I was full of dreams and excitement for the future. Life was a vibrant tapestry of school, music, friends, and endless possibilities. But in an instant, everything changed. I had a stroke. At 13, I found myself in a place I never imagined, facing a battle I didn't even know it existed. The first thing that struck me was the confusion. One moment, I was laughing with my friends on the phone, and the next, I was surrounded by machines, doctors, and shattered glass. My world turned upside down. The stroke stole my ability to move, speak as I used to, and suddenly the simplest tasks became monumental challenges. As a teenager, it's a time when you're discovering who you are and who you want to be. But I was forced to confront a new reality where my independence was stripped and my dreams seemed distant and unreachable. It was a time of profound fear and frustration. I questioned, why me? Amidst the darkness, I discovered something incredible. I discovered strength I didn't know existed. I learned that resilience is not just about bouncing back. It's about embracing the new path life has set before you and finding new ways to move forward. For over 31 years now, a lifetime, I've been fortunate to have the support of my family, friends, incredible work colleagues and mentors who have guided me and believed in my potential. They have all reminded me that my voice mattered and that my experiences could and do make a difference. Through the journey, I found a purpose in sharing my story, in advocating for others who have faced similar challenges. When I became the consumer consultant here at the Florey, working on various projects to provide a perspective that only someone with lived experience could offer, I realised that my struggle could pave the way for change and understanding in the medical community. Each day is a step towards reclaiming my life, not just because it was and is something new and extraordinary. I've learned that setbacks are not the end of the road, but rather the beginning of a new journey far too early in life. However, it can be filled with unexpected opportunities and profound connections. At 13, I never imagined I'd be standing here today, sharing my story with you. But life has a way of surprising us, of pushing us to become more than we ever thought was possible. My stroke has been an endless chapter in my life, but it does not define my story. It's helped shape me, it's definitely challenged me, and ultimately, it's empowered me.
Well, thank you very much. An extraordinary story, and just a testament to overcoming the most extraordinary adversity. So you really stand as a bastion of hope for us all. I might open it to the panel and get a sense of how the panel perceives the major challenges facing people with stroke. And we've heard Brooke's perspectives there, but open it to the panel for your perspectives. What are the big challenges?
I think, hi everyone, I'm Professor Dominique Cadilhac, and I have a background in nursing as well, so we are really interdisciplinary on this panel. From the data that we've been collecting in the registry, where we also learn that many people leave hospital with little information to help guide their care, but also to communicate with their primary care providers, so their general practitioners. They also, we send out a survey at 6 months to see how they're going. And when they respond, 1 in 2 will tell us that they don't really understand what's happened to them and they want information about their stroke. So I would see that we have challenges not only in the way people come into hospital and making sure they get the treatments that they need, and that we reduce variation so it's not a postcode lottery wherever you have your stroke, that all hospitals will treat you equally and you have access to best practice care. But on that onward journey, this journey that Brooke has talked about, that you have the information you need to understand what has happened to you, what a stroke is, how to prevent it, and how to get support for your ongoing recovery journey, because it is not something that's going to happen in a month or 3 months. It is a lifelong process. And I think partners in that include general practice, and I think we need to do more to work more hand in hand across the healthcare system.
I've spoken about some challenges in terms of what we call implementation. Doing what we know works is a big challenge. Of course, there will still be people that receive best care and then still are not cured from their stroke. And there we need, I think, discovery science. Things that here in these labs are happening. How can we really target acute damage to the brain, but also can we improve on how do we impact the repair mechanisms and make them work better in people that have a stroke. So I see that as the biggest challenges for decades to work on, unfortunately, because it takes a lot of time. These things need a lot of support and infrastructure to get going. So that's my perspective as a neurologist.
Thanks. And I'm Leanne, and from a recovery perspective, I think, Brooke, you set the scene very clearly. You know, stroke, survivors of stroke have ongoing challenges, and I think that's one of the prime things that stands out there, isn't it? That there are ongoing challenges, and people often then only really experience those when they're discharged home. The problem is that once you're discharged home, there's often those unmet needs. And people also don't even necessarily know how much can I continue to recover, because I know, unfortunately, sometimes the messaging is that the recovery occurs early, 3 to 6 months, and then that's a real threat, a real scary time to sort of go with. But we know that people want to recover. They want to go back to the things that are important to them, and they need to be able to open the door to really engage with people as they're involved with to do that. The other thing that we hear from the lived experience partners we work with is often they feel like they fall off the edge of a cliff. that once they've discharged from hospital, it's really hard to navigate what's out there. As Vincent said, you know, access is an issue, limited rehabilitation is an issue. But what's the hope? There is hope. And I think the thing is we're really starting to get our hands on that, to bring that together. And I think it's working together in these sorts of teams that allows that there is hope. We know, particularly at the Florey, the brain is plastic. It has an incredible capacity to recover, to learn new skills. So the myth of 3 to 6 months is a myth. It's not true. There are ongoing capacities to learn and recover over time. So our mandate is to work together to work about how we can do that.
Vincent, can you give us an insight into how life stage influences the experience of stroke?
Well, I think, of course, what you need to know is that a stroke is quite individual. If brain has many blood vessels, any blood vessel can be affected, so it's hugely variable. But if you're younger, typically your recovery will generally be better. For the same severity of stroke, you typically will have a better recovery, but that's using the tools that we use to gauge recovery in older people. So what often happens is, if you look at return to work, well, many people in their 70s or 80s will not be working anymore. But that's a big challenge for a person who's 30 or an 18-year-old who wants to go to university. So with a young stroke service, that's really the challenges that we are trying to face. If you can't drive, well, maybe when you're 70 or 80, that's of course a big challenge. But when you're 25 and you need to go to work, that's a big hurdle. So how can we make that happen? And we see that often in the community that's addressed in one rehab center very well and in the other not. So that is the experience can be quite different to which postcode you live. Stroke at middle age has certain other challenges. The presentations are quite similar, but of course then it becomes recognized more easily because it's sort of known that people that are in their 50s and 60s can get a stroke, and especially if you get even older, it becomes more and more common, and the whole health system is focused on that. When you're younger, you're often mistaken for another condition. Oh, it's probably a migraine, or you're sent home early on because you've recovered and you're doing really well, but then the challenges occur. So the challenges are maybe similar, but the degree to which they affect your life can be very different. And that's why we have this young stroke service that we hope really can be sustainable in the future and also spread out across Australia.
Fantastic. Dominique, I might turn to you. Can you tell us what the data is saying? Where can we improve stroke care?
Well, there's lots of different areas. I think Vincent highlighted some of our data from the slides, but if only 1 in 3 people are getting treated within the time windows, that's a real problem. Why is that a problem? Because for every minute of delay, that is 1 day of healthy life being lost. So if you delay by 60 minutes your treatment, that is 60 days of healthy life that's being lost from all the ongoing brain cell death that's occurring. That's one area. The other area is, of course, making sure that everybody gets access to specialist stroke care through stroke units. Now, this requires having access to speech pathologists, physiotherapists, occupational therapists, nursing staff that actually understand the needs of people with stroke, how to look for complications, and how to help support that early rehabilitation and recovery. So we learn a lot about the quality of care in hospitals through whether or not people are getting access to the treatments they need and in a timely fashion, but also what's happening to them in that discharge care process. Our data have given us insights into variation between what happens to young men compared to older women. Older women have, may not necessarily get all the prevention medications. Older people that have more comorbidities seem to do better overall in their quality of life when we measure that at 6 months. But younger people that have a number of comorbidities do really poorly. So the depth of information that we collect really helps us pinpoint, but also understand the different needs of people. So where is it that we might need to target support in a certain way for women compared to men, or different ethnic groups, for example?
So important to be able to understand that, because how on earth could we change things for the better if we don't even know what the issues are? So it's really, really important practical research. Leanne, I might turn to you. We know that stroke is the leading cause of disability. What role is there for rehabilitation to minimise the disability of stroke?
It's an incredible role. In fact, I was had a meeting this morning with our lived experience partners, and I said, what do you think about that? She said, massive role. So it is really important. It is one of the vehicles that help us move from what a person experienced through to being able to function again, to be able to return to valued activities from home. So that's a really critical part of it. And I think it's particularly critical when we're prepared to step forward and take the active or more restorative approach to rehabilitation, because rehabilitation can be varied. And I think here, particularly at the Florey, and it has been my life journey, is bringing the neuroscience to rehabilitation, and we call it neuro-rehabilitation. So what's important for us to understand is that the brain is plastic, that it has an incredible capacity to learn and adapt, and individuals who have experienced a brain injury in fact have a greater capacity for that learning and adaptation. So the question is, how can we harness it? And there are very real ways that we can actually do that. And so I think the other part that I, again, this morning had this conversation with our lived experience partners. It was a survivor of stroke and their partner. And I said, okay, well, what's important here? And they said, make sure people understand about this potential. Make sure there's more education out there about this neuroplasticity and the fact that we can tap into it through rehabilitation. So I think that's an important part of it. We've been looking to try and do that in a number of ways. So one of the examples was Karen that Vincent showed you on the slide. She's a young stroke survivor, a young mother who had lost the sensation through half of her body. So imagine what that is like if you can't walk down to the park holding your daughter's hand safely. You can't hold on to a knife with a fork without it slipping out of your hand. So what we have learned is the ways that we can shape, use specially designed training tasks, guide them through the actual application to the activities that are of value for them, and we see improvement in the sensation, in the use of the arm, in the activities that are important and what they're able to go back to. So we're demonstrating evidence that this more active approach has potential and has very real outcomes for people. The other thing, though, to consider there is that sometimes when we see these improvements in the therapies, it doesn't always reach everybody because it doesn't always change the practice of the therapist straight away. So the other big part that we've been involved in is developing a national network of clinicians and partners, so right from survivors of stroke to clinicians to researchers, policymakers, to develop a network. So we've actually engaged 8 healthcare networks as well as developed 4 sense specialist therapy centres to upskill over 150 therapists to deliver this sense therapy. So that's been an important thing. And the last thing that we're taking that now to is trying to personalise the recovery. So this is where we want to stay connected with people when they're going home so they don't feel like they're falling off the cliff, but personalised recovery. So we're using sensors and apps to ask the person what they're doing and how they're feeling about how well they're doing that. We use that to help monitor when's the best time to introduce the more active therapy and make sure it's targeted to the activities. And then we deliver bursts of therapy that are very much tailored to that individual. So we're using artificial intelligence to help bring all that body of information together, as well as we're allowing people, or sort of promoting doing it in the home. So we're able to have the therapist on one side and have the survivor of stroke and perhaps their partner doing the therapy at home. And now in real time, they could be taking a picture with an exoskeleton of my hand so that we can actually get greater insights to the movements and be able to use that in real time to give feedback. And we use the cloud and Google to actually do that now. So it's really quite exciting.
I can imagine that everyone's busting to ask questions, but before I throw to the panel, I'm just going to ask one final question to Brooke. Brooke, you've been a very valuable member of the stroke team yourself, contributing to research. Can you tell us what your experience of that has been?
Absolutely. So I think that I've been a very valued member, starting out as a volunteer over 2 decades ago. I know I don't look any more than 21. We'll hold it at that. It's been incredibly rewarding and a transformative experience. It has allowed me to contribute to meaningful research. I've been able to advocate for stroke survivors and witness the profound impact of collaborative efforts in the field of stroke recovery and rehabilitation. On a professional group level, there's been working alongside my esteemed professional colleagues like Professor Julie Bernhard and Professor Vincent Teague and Professor Dominique Cadilhac and Professor Leanne Carey. It's been an incredible opportunity for growth. Their mentorship and support have been invaluable, providing me with insights into the intricacies of stroke research and the importance of multidisciplinary approach. This collaboration has also enhanced my advocacy skills, allowing me to effectively communicate the needs and challenges of stroke survivors to researchers and even policymakers. The research team is a dynamic and collaborative environment where every member's input is valued. Being a part of this team has reinforced the importance of teamwork and the collective effort required to drive innovation and translation in stroke trials. It's inspiring to see how different perspectives come together to tackle complex problems and develop new strategies for stroke prevention, treatment and recovery. My involvement in various projects, including the Lived Experience Advisory Group for the Young Stroke Service and other groups here, statewide and also internationally, has provided a platform to advocate for better stroke care. These roles have allowed me to highlight the real-world challenges faced by stroke survivors and advocate for change that can lead to improved quality of life and better support systems. On a personal fulfilment level though, one of the most fulfilling aspects of being a part of my stroke research team, I say they're mine, is knowing that my lived experience can and does make a difference. Providing a consumer perspective has been empowering. It has ensured that the voices of stroke survivors, not just mine, are heard and considered in the research process. It's gratifying to know that my contributions can help shape more patient-centred approaches and improve outcomes for others who have experienced stroke. Being a part of my team is not without its challenges though. Balancing my personal recovery with professional responsibilities does require resilience and dedication. However, these challenges have also strengthened my resolve to make a difference and have given me a deeper understanding to the complexities involved in stroke research and recovery. So if I may look forward, and I continue my journey with the stroke research team for many, many more moons, I am excited about the future. There is still much work to be done, and I'm committed to contributing to advancements in stroke care and rehab. The support and encouragement from my colleagues, mentors, and the broader stroke community, so all of you here tonight are a part of that, have led to fueling my passion and drive to continue this important work. In conclusion, being a part of this stroke research team has been an enriching experience that has profoundly impacted my personal and professional life. It has provided me with the opportunity to give back to the community, advocate for those affected by stroke, and contribute to research that has the potential to change lives. I am grateful for the journey I have been on, and I continue to be grateful for the positive impact in the field of stroke research.
Extraordinary book. I'm sure that has fueled the fires amongst you to ask questions. So at this point, I'll open the floor to questions. We do have a roving mic.
Your rehabilitation in this country has gone backwards. You've got a stroke patient who's admitted across the road, is discharged at 4 or 5 days medically, waits for 6 weeks for a physiotherapist to come, of which they're only entitled to about 4 or 6 sessions, and after that is arrivederci, goodbye. This is a government issue. This is a social issue. The government does not look at any issues at all. If you require an AFO because you've had a CBA, forget about it. You are not going to get it. You go on the waiting list for SWEPs in Ballarat, they'll tell you there's no funding available. This has been going on for years. Medically, we are on top of the world in treating stroke. Thank God to people like Steve Davis and Jeff Donnan and that team. We've got a stroke ambulance, which is restricted in time limit because of funding.
Thank you. Yeah, I think
we can go on and on and on.
No, it's clear that you're very well versed in this, and also, you know, you're clearly very passionate, and I think you make some very important points, and I think we have to recognise that we have power as members of the public to lobby the government for change. And it's voices like yours that are so important, that are heard by local members and the like. I can speak, you know, on behalf of the researchers to say that we can generate the evidence, we can provide the pathways to change, but it does require a political mandate, and we are working very hard towards that. Any members of the panel want to respond?
Well, I was just going to comment that, it's difficult to get access to rehabilitation, and that's why we collect that kind of data through the Australian Stroke Clinical Registry. We know only 1 in 4 get access to inpatient rehab, and in inpatient rehab, where you get to stay overnight for up to maybe 4 weeks, that you have the most amount of therapy because the dose of therapy counts. Like, we have guidelines that tell us people should have 3 hours of therapy a day, and it's very difficult to deliver that. So you are spot on, and we use our data to help try and drive change in the system, and that's why it's really important that we have now got data and a system of collecting information, and when we collect and join and link that data to other data that is held by the Rehabilitation Outcomes Centre, by other information that's held by government on patient journeys from when they get put in an ambulance to right out beyond, a year or 2 years, but also what treatments they've had. So let's use that data wisely and also have the voices of the community help support that. But as Peter said, we help generate the evidence, and then we need a way in which we can use that evidence to do good.
I understand that people who have strokes that are the result of a clot, need to get to hospital quickly, etc. But I'm not quite sure what happens in the stroke episode for someone who has high blood pressure and the blood vessels break down. So could you please tell me, is there a difference in the lived experience when you first start having the stroke? What type of treatment is ideal for that type of stroke? And is it more catastrophic an event, which I hope it will be if that's the case for me, that, you perhaps don't survive, but at least you know ahead of time that that's more likely?
One for Vincent.
So brain bleeding is indeed less common and generally tends to have worse outcomes. So there's a higher mortality, it leads to a higher rate of disability, but there's positive news. Now we have generated quite good evidence that early treatment with blood pressure reduction helps improve outcomes, and there's the first clinical trial, just like I spoke about the trial that I witnessed, changing practice now, that specialized surgery also may help in selected cases. So we're really at the brink of a new era of treatment for brain hemorrhage. But indeed, it's a little bit, it presents in the same way as a stroke. You can not tell by examining, by any clinical sign, that it's going to be a hemorrhage or a blockage of a blood vessel. You need to do a brain scan to see that. And now we have treatment also available for the brain hemorrhage. It's less successful. We must admit the damage often is already there. We try to limit further damage, whereas with a stroke, with a blockage, you can actually reverse the damage, which is quite spectacular. So two different types of conditions, but they're presenting the same for the community. The prevention is exactly the same. Know your numbers, know your blood pressure numbers, know your cholesterol, and check your heart rate if it's regular. If it's irregular, go see your doctor. Those are the important messages. Know your cholesterol levels, etc.
So a brief follow-on question, Vincent. Are the risk factors the same for both types of stroke?
Absolutely, yeah. Only the irregular heartbeat is less a risk factor for brain bleeding, but high blood pressure, cholesterol, diabetes, they all contribute to having a stroke, regardless of the subtype.
So we can modify our risk for stroke. Next question.
A brief one. What's involved in the administration of clot-busting therapy?
Like we said before, we have to examine the person, and then we have to do a brain scan, and if there's a blood vessel blockage, we can sometimes see that on the scan, sometimes not, but we presume it's there. As long as there is no bleed, we can administer the medication. It's an intravenous medication. It can be, there are two types. One is given over 1 hour, and the other is just an injection given over a minute. So relatively easy, straightforward to do. Still takes about up to an hour in Australia. In other countries, they're getting 30 minutes. So we also need to work harder on administering it quicker. Time is brain.
So I think, Vincent, you're a young man, and I think the profound thing is that in the span of your career, this has gone from being an untreatable condition to a condition where we can make a big difference in the acute setting, but also we've heard about, in the more chronic stages of recovery. So that's extraordinary to reflect on, that things are changing. Clearly, there's a long way to go in terms of universality of that implementation, but I think there's a lot of hope to be gained from that. We might have time for one more question.
Having accidentally tipped into the older women category, 2 years ago I was in Hawaii and had 4 small strokes. They discovered the carotid artery was 95% blocked. I had surgery. At the end of my time in hospital, they prevailed upon me that when I came back to Australia, protocol was that I should have right carotid surgery. Back in Australia, the physicians looked at me in horror. What? No. Would you speak to that, please?
It's a very specific question. So so there are some blockages in the neck, blood vessels that supply blood to the brain, and they can sometimes lead to symptoms. That's when we call them symptomatic. And then there are also that don't lead to symptoms. And there we see that there are quite cultural different approaches to us, and that's why you see variation in practice in the US, where they will tend to operate it. In Australia, there's more a consensus to stay away from that and monitor it and control the risk factors rather than having a preventative surgery. You know, preventative surgery means that you're operating on a person who's essentially feeling well, and the surgery has a risk and a relatively small benefit, and you need to balance that. And that equation is made usually in partnership with the person. Some countries will say, we don't fund this. Some countries will say, it's your individual decision on what you do. And then there are different styles of physicians. Some will be a little bit more aggressive. So you see that variation of care will be seen. But we tend to try to come together and have recommendations and guidelines by reasonable people where we take all the evidence into account, and sometimes that evidence changes over time, and sometimes we see these little cultural differences. But it means that it's not really a breakthrough treatment to having that surgery or not. It's probably just a little bit in the margins for society as a whole. For an individual, it can make a big difference. Absolutely.
Fantastic. So I'm sure you'll all agree that it's been a very fascinating and lively discussion, and I'd like you to join me in thanking the panellists for their contributions. And to members of the audience, I'd like to thank you very much for joining us this evening and for participating. I can see that there's plenty more questions for the foyer. We hope that it's been informative and engaging for you, and we really appreciate your interest in the great work that's being done here at the Florey. We really are committed to making the research that we do in this organisation approachable and relevant to our community, and we're very passionate about that. I'd like to reiterate my thanks to members of the Stroke Foundation who are here tonight, but also for their commitment to such an important program of health promotion with the F.A.S.T campaign. I'd also like to acknowledge that events like this take quite a bit of planning and quite a bit of work, so we have thanks due to members of the Florey team who've made this possible. Finally, if you feel inspired by the work that we're doing in stroke research, please consider making a donation to the Florey. From day one, the work that we have done to advance brain research has been made possible thanks to the generosity of donors, and we're tremendously grateful for this vital support. And so a special thank you to those amongst the audience who've been donors to the Florey. We're very grateful for your contributions. Please feel free to use the QR code if you'd like to find out about more ways to contribute to the Florey. And if you're not au fait with using the QR code, please reach out to members of our team who you can identify they're wearing the big white badges. So tonight is one of a wide array of Florey public events, and we'd be delighted to see you again at future events. So please join me in the foyer to enjoy some refreshments, and thank you very much.